Hello, my name is Dr. Norman Lepore, clinical professor of medicine at the Geffen School of Medicine at UCLA, attending cardiologist at the Smith-Cedars-Sinai Heart Institute, director of clinical research at Westside Medical Associates of Los Angeles. I'm happy to be making a presentation on what will be an increasingly important topic for those of you who are involved in mitigating cardiovascular risk, in particular the treatment of lipid disorders. What we're going to talk about today is an update on lipoprotein A, otherwise known as the horrible cholesterol. So in terms of the story behind lipoprotein A, hyperlipoproteinemia in humans is associated with an increased risk of cardiac death, myocardial infarction, stroke, aortic stenosis, and peripheral arterial disease. It's clear from epidemiological genome-wide association and Mendelian randomized controlled study data that there does seem to be a very important role for lipoprotein A as a risk factor for cardiovascular disease independent of cholesterol, LDL. Lipoprotein A seems to adhere to plaque sites and is retained in the arterial wall, where it has pro-atherogenic and pro-inflammatory properties due to both its LDL and ApoA moieties. LPA may also be thrombotic, prothrombotic by inhibiting fibrinolysis because of its structural similarity to plasminogen and its potential enhancement of platelet aggregation. In addition, this part of this lipoprotein A story, we know, as just mentioned, it regulates expression of plasminogen activator inhibitor, which actually enhances clot formation and reduces clot lysis. It inhibits endothelial cell surface fibrinolysis, thereby enhancing local thrombogenicity. It actually may be an attractant of macrophages to the atheromatous plaque. Cellular uptake of the lipoprotein A molecule mediated by the VLDL receptor may contribute to macrophage foam cell transformation, which is a critical part in the development of plaque. And lipoprotein A has also been found localized in plaques in patients much more frequently in acute coronary syndromes than those with chronic stable angina, and seems to be located in areas of the plaque that seem to be populated by macrophages. So this is what the lipoprotein A molecule looks like. It's such a pretty molecule, but it's so destructive. And you can see that its components include the ApoB100, it includes oxidized phospholipids, and you can also see a tail consisting of a variety of kringles. And the number of kringles that each molecule lipoprotein A has really defines their unique character, their molecular weight, and also their propensity for atherogenicity. And you can see there's a large variance in terms of the number of kringles, which really is based on genetics and DNA. So the number of kringles that you may have on your ApoA, it may vary in a very different way from those of those around you. So there's high variance in terms of the number of kringles, and therefore there's a very large variance in populations between the actual appearance and concentrations of lipoprotein A. One proposed mechanism of action for the effect of lipoprotein A is actually both the attraction as well as the activation, apoptosis of macrophages. We know that macrophages play a very important role in atherogenesis, as well as a very important role in terms of plaque susceptibility to thrombosis. So we know that by virtue of the attraction of the macrophage, the induced oxidative stress, and therefore apoptosis of the macrophage, this leads to a cascade of events that makes the plaque more likely to be involved in a thrombotic process and be more vulnerable. So this is a schematic of what happens in terms of the role of the macrophage in plaque development. And we see you have the attraction of the plaque by macrophages. You have proliferation of these macrophages, which are activated. Cell death, as we just talked about, leads to a release of a whole variety of cytokines, including interleukin 8, interleukin 1 beta, and tumor necrosis factor. And all these factors play a very prominent and important roles in terms of furthering the development of plaque predisposition to thrombosis. And in this schematic, in this autopsy specimens, what we see here in plaque in C is actually staining for macrophages. And you can see the intense staining for the macrophage at the edge of the plaque on the right side. And in frame D, what we see is a staining for actually lipoprotein A, which seems to appear in the same areas. So we see that lipoprotein A seems to have its effect in terms of concentrations and such in areas where there's active macrophage attraction. So let's talk about now lipoprotein A levels and cardiovascular event risk, because this is what really is the guts of what we are concerned about with lipoprotein A. It's clear in terms of observational studies that there is a definite increased risk of myocardial infarction, valvular aortic stenosis, coronary artery stenosis, parotid stenosis, ischemic stroke, peripheral arterial disease, heart failure, cardiovascular mortality, and all-cause mortality with lipoprotein A concentrations. So there's clear from observational studies as well as Mendelian randomization studies that lipoprotein A is associated with a variety of cardiovascular maladies. And what we see from this recently published data from Jack from the Journal of American College of Cardiology, that as your lipoprotein A levels increase as you go on the x-axis from left to right, you also see a dose-related increased risk of cardiovascular events. And for the most part, we actually will call, in terms of nanomoles per liter, an abnormal lipoprotein A level in terms of acting as a risk factor for cardiovascular disease, a level above 150. But you can see that in terms of increased risk, that increase in risk actually starts at concentrations of lipoprotein A that are considered normal. There certainly seems to be a relationship between LPA levels as well as non-fatal MI that we can see on the left, as well as not quite as robust, but still a relationship between lipoprotein A levels and ischemic stroke. Lipoprotein A is also can be very useful in terms of enhancing our ability to risk stratify patients for coronary heart disease. And what we can see here is the information gleaned from taking a family history in terms of a hazard ratio for being able to predict cardiovascular events is enhanced by taking the information from the lipoprotein A level. So therefore, using the lipoprotein A level can further enhance our sensitivity and specificity and improve our risk discrimination and reclassification of risk. So I think this is important, and perhaps why it's important that we be more assertive and aggressive in really determining lipoprotein A levels in patients that we see in our cardiology clinics. What's not quite as well known is the fact that the progression of aortic stenosis and complications of aortic stenosis are also increased in patients who have elevated levels of lipoprotein A, and this may be related to the same and a similar pathophysiology as we see with patients who develop coronary artery disease as a result of lipoprotein A, both in terms of macrophage proliferation, enhanced fibrosis, but there certainly is a clear relationship between lipoprotein A and aortic stenosis. And we can see here that this is a concentration risk as the lipoprotein levels increase. We also see the increase in both age and sex adjusted, as well as multiple variable adjustments in terms of the development of aortic stenosis. So again, this is consistent with LPA being associated with the risk of aortic stenosis. And interestingly, what we found in the Fourier trial was similar data. Somewhere out about 540 days, we see this increased incidence in terms of aortic stenosis. And certainly around 540 days, we see actually in the patients treated with evolocumab, we see a reduction in terms of the complications of aortic stenosis. So there may be something to be said for the effects of LDL lowering and even the mild lipoprotein A reductions that we see with the PCSK9 inhibitors. And we can see that this reduction in terms of aortic stenosis seems to occur somewhere around the 1.5-year mark. We also find in the PCSK9 inhibitor trials that those patients in whom there are elevated levels of lipoprotein A, we tend to see an even more robust reduction in cardiovascular events in these patients. What you can see in both patients in Odyssey outcome trial, where the patients had lower LDLs at entry into the trial, and even those patients who had, as you can see lower on the slide, higher LDLs, those patients that had elevated levels of lipoprotein A were associated with a greater benefit from the PCSK9 inhibitor. This is similar to what we see in the Fourier trial, where those patients who had elevated levels of lipoprotein A seem to have even more protection from cardiovascular endpoints with evolocumab. So therefore, LPA may actually define an increased risk cohort. Therefore, patients at increased risk would be expected to have an enhanced absolute risk reduction by virtue of a treatment, and also perhaps may be related to the modest LPA reductions that we see in the 20% range with the use of PCSK9 inhibitors. And just to make it even a bit more complicated, LPA from studies in the Copenhagen City and general population study also showed a predisposition towards the development of heart failure. And perhaps that may be based on the increased incidence of ischemic heart disease, perhaps even as well in terms of aortic stenosis, but certainly a relationship in terms of the development of heart failure. Now, what's interesting, if we look at this particular slide, what we can see in terms of being able to mitigate cardiovascular risk with lipoprotein A, it really takes very robust, drastic reductions of lipoprotein A levels in order to achieve such reductions. In fact, you can see, looking at the LDL-C levels and reductions of coronary heart disease risk, we're talking about looking at genetic estimates. So we're talking about patients looking at Mendelian studies versus the short-term trials that we explored the efficacy of the statins in particular. And on the right, looking again at the genetic estimates based on the Mendelian studies, as well as predicted reductions of risk, basically to achieve the kinds of risk reduction that you may obtain with lowering LDL cholesterol by about 40 milligrams per deciliter, you actually have to lower absolute concentrations of lipoprotein A by about 100 milligrams per deciliter. So the point I'm trying to make is that it takes compounds that can achieve 80–90% reductions of lipoprotein A levels in order to be able to achieve a significant coronary heart disease risk reduction. So at the present time, there are no commercially available targeted treatments to reduce lipoprotein A. We know in terms of conventional lipid therapies and their effects on lipoprotein A levels, that statins may actually increase lipoprotein A. Ezetimibe can reduce LPA. PCSK9 inhibitors reduce LPA by approximately 20%. Estrogen reduces lipoprotein A as well as niacin. However, for the most part, lifestyle modifications do not make any change in lipoprotein A levels. And another important aspect is actually lipoprotein A levels do not change much in life. So all you really have to do is measure a lipoprotein A one time in a person's lifetime, because again, it's not really affected for the most part by age or by changes in lifestyle, the kinds of changes that we can actually see with cholesterol levels. So this is looking at some of the selected available agents or procedures that affect LPA levels. And what we see, for instance, lipid apheresis can acutely reduce LPA levels by 70%, but really on time average by about 35%. And you can see down the line, the things that we talked about: nicotinic acid, 20 to 30%, PCSK9 inhibitors, somewhere about the 20 to 25% range, mipomersen, 20 to 40% reduction. Statins, you actually get an increase. And ezetimibe and the fibrates, for the most part, are neutral to minimal reductions of lipoprotein A levels. Let's talk about really what's really exciting and new in terms of potential important treatments for reducing lipoprotein A levels. Generally, you can see on the left side of the slide where we talk about small molecule drugs. They basically are made by the pharmaceutical companies, and they can actually get into the cytosol of a cell and exert their effect on enzymatic processes, like a statin. A statin gets into the cell and inhibits the cell reaction called HMG-CoA reductase. We also have biologics, such as, for instance, the PCSK9 inhibitors. These are IgG molecules which actually bind PCSK9 by virtue of their protein effects. And but these effects really, for the most part, occur and at the molecular level and really don't affect the synthesis of compounds. Whereas the RNA targeting actually targets the messenger RNA for a particular protein and therefore blocks protein synthesis. And the target is actually within the cell cytosol. So what we're really targeting is mRNA. Now, there have been some really important developments in terms of RNA technology. One is the ability to create these moieties that bind to the particular effector molecule, which in this case could be the silencing or the antisense nucleotide. And basically what you do now is, in order to get them to in this case, the target hepatocyte, you actually bind to these molecules what we call a GalNAc, which is an N-acetyl-galactosamine. And this actually is specific for that receptor you see on the right, the ASGPR receptor. And this ASGPR receptor, the asialoglycoprotein receptor, is very specific for this particular moiety, this N-acetyl-galactosamine moiety. So therefore, if you bind your RNA, your synthetic RNA molecule with this GalNAc, we call it, it actually leads to specific binding to the hepatocyte and therefore much less binding to other tissue, making these drugs less toxic, and also being able to target the hepatocyte, need to use lower concentrations of such drugs. And so this is really an example where you see on the lower end this GalNAc conjugation. It binds to this ASGPR receptor. It's then internalized into the cytosol, where the GalNAc conjugated aspect of the molecule will actually then become disbanded, and the synthetic RNA molecule can exert its effect. And this is actually shown very nicely in this particular slide. We're talking about the two main types of RNA degradation. So we're really talking about this antisense oligonucleotide, and we're going to talk about an example of that being pelacarsen, and that you can see on the top, which is a single strand of synthetic RNA that's actually internalized into the cytosol. It actually has attached to it in the cytosol this RNase molecule, which will eventually break down the native mRNA. And what you then have is you have the binding of this synthetic RNA to the targeted mRNA, leading ultimately to its degradation. And when you degrade the mRNA, it will no longer be able to translate and lead to protein synthesis of that particular molecule. So that's the process, what we call ASO. It's the antisense oligonucleotide. And then lower down, you see the silencing RNA, which is sort of similar by virtue of the fact that it also degrades the native mRNA. But this is actually a double-stranded RNA. And when it comes into the cytoplasm, what we call the passenger strand actually uncoils, and then you then have this, what we call the guide strand. It actually binds to this complex called the RNA-inducing silencing complex. And by virtue of this binding, eventually what you get is actually the degradation of the native mRNA. And what's really interesting is that you actually have a recycling of this guide strand RNA. So you can have this continuous process going on in the cell for weeks after, where you get continuous degradation of the mRNA. So both the ASO, which is the antisense oligonucleotide, as well as the silencing RNA, both ultimately lead to the destruction of the messenger RNA. That's particularly the messenger RNA that is coded to lead to a specific protein synthesis. And in this case, we're talking about apoprotein A. So you have the ASOs and the silencing RNAs share important similarities as drug candidates. Both platforms are intended to modulate gene expression. Both are nucleic acids and contain an antisense strand intended to recognize the target mRNA that then leads to its destruction. They also have important differences, as I mentioned. The antisense oligonucleotides are single-stranded, while the silencing RNAs are double-stranded. This leads to the silencing RNAs actually having longer half-lives. So let's look at the clinical trials, because to me, these are really exciting. And I think we're going to hopefully see some very exciting news from cardiovascular outcome trials within the next 3 to 5 years. So first, what we'll talk about is pelacarsen. So pelacarsen is an antisense oligonucleotide. My site at Westside Medical Associates of Los Angeles is involved in this phase 3 cardiovascular outcome trial, where we're enrolling patients who have a history of myocardial infarction, a history of ischemic stroke, or significant peripheral arterial disease. And what we can see from this earlier phase 2 data, looking at this analysis, they are actually able, by virtue of concentrations of pelacarsen given every 4 weeks, you're actually able to reduce LPA levels in the 80% range. This is the range that we think it's necessary in order for it to have its effect based on the Mendelian studies. So this is looking at pelacarsen as an antisense oligonucleotide, and we're currently in phase 3 cardiovascular outcome trials of this particular molecule. That study is called the Horizon trial, as we talked about, looking at patients with elevated lipoprotein(a) above 70 milligrams per deciliter, who have the comorbidities I've mentioned in terms of history of MI, history of ischemic stroke, or significant peripheral arterial disease. So what they expect to do, if you look at this, is on top of this slide, what we see is a population frequency distribution of lipoprotein(a), and you can see in the green, those are patients that we would say have, for the most part, normal lipoprotein(a) levels. And as you can see, as you go towards the right, the colors merge from orange to red being the very high levels. And it's the red are the levels that we're targeting in this cardiovascular outcome trial, these very high lipoprotein(a) levels. And if you can see lower down on the chart, what we're going to do, hopefully, with pelacarsen is be able to modify the LPA levels from the red zone and reduce those levels of LPA, really, so they really represent what would be considered normal in the general population. In terms of the adverse effects of these antisense oligonucleotides, for the most part, although they're being studied intensely now in the CV outcome trials, it seems for the most part that the major adverse event is similar to what we see with the PCSK9 inhibitors, or some mild injection site reactions, but we're taking a very close eye looking for any evidence of, obviously, liver toxicity or hematologic abnormalities, such as reduced platelet counts. So the other compound that is that we're also involved in terms of clinical trials at Westside Medical Associates Los Angeles is olpasiran. So olpasiran, though, is the silencing RNA, and what we can see here is looking at this particular drug study to determine optimal concentration of drug to be delivered. What we're seeing here is similar, is this 80–90% reduction of the lipoprotein(a) level. Again, what we're doing with both of these drugs is reducing the synthesis of ApoA. So let's talk about LPA and when do we consider the risk factor. According to the 2018 AHA-ACC lipid guidelines, a relative indication for its measurement is a family history of premature ASCVD. So you have the patients who have a robust family history. An LPA level greater than 50 milligrams per deciliter, which is similar to 125 nanomoles per liter, because LPA levels, depending on the lab, are measured with these two different units, constitutes a risk-enhancing factor, especially at higher levels of LPA. So if you're on the fence on whether you need to treat an LDL, like we talked about earlier, the lipoprotein(a) elevation may actually tip the balance towards their being treated more aggressively with lipid-reducing therapies. So this, again, would be populations to consider lipoprotein(a) testing. Primary prevention, where you have a first-degree relative with premature ASCVD, patients with severe hypercholesterolemia or suspected heterozygotes or homozygotes for familial hyperlipidemia. Those patients with borderline risk, where you're not sure whether or not they need to be treated with lipid-lowering therapy. Important that you actually do cascade screening of family members with particularly the genetic hypercholesterolemias, because lipoprotein(a) does seem to be associated with it. And we talk about risk enhancing factor in patients at intermediate risk. In terms of secondary prevention, I think the thing to really focus on is looking at patients who have premature atherosclerotic coronary vascular disease. They have a particular aggressive and progressive ASCVD, perhaps they have multiple vascular territories, early events, patients with ischemic strokes who are less than 55 years of age, and those patients who have ASCVD and also have significant family histories. So measuring LPA in this particular situation will help with risk assessment, and being able to identify these patients now may actually allow you to include them either in clinical trials or when we do have, hopefully, molecules that will be commercially available to actually take these high-risk patients and actually target their lipoprotein A levels. So in summary, it's clear that lipoprotein A is associated with an enhanced risk of cardiovascular events, such as myocardial infarction, stroke, and peripheral arterial disease, and actually seems to be possibly an important new target for risk reduction. Lipoprotein A is also associated with the development of aortic stenosis and maybe something to look for in your patients who are presenting with either significant aortic sclerosis, which is a precursor of aortic stenosis, or early aortic stenosis. Reducing hepatic synthesis of lipoprotein A by the use of both the silencing RNA as well as the antisense oligonucleotide. The silencing RNA olpasiran is in clinical trial, as well as pelcarceran, which is the antisense oligonucleotide, are now in clinical trials, and they are used to actually block the synthesis of ApoA, which is an important component of the lipoprotein A molecule. And these are now in clinical trials, including cardiovascular outcome trials. And I think what we should do is certainly consider measuring lipoprotein A levels in patients with accelerated coronary vascular disease, those patients with significant family histories. Also, when a routine lipid profile does not explain that patient's cardiovascular risk and cardiovascular disease presentation. I hope you learned something from today's presentation. I appreciate your attention, and please feel free to let me know if you have any comments or questions. Thank you very much.